Health meeting. We do have a quorum, so we're gonna go ahead and get things live. Tim, you give us a thumbs up when you're live on the YouTube. Very good. All right. Do we have it? Ed, will you do invocation for us?
Sure. All right. Heavenly Father, thank you for those gathered here. Thank you for our time together to do the business of people in this county and on their behalf. Be with us and give us wisdom and guide us in the things that we do. In your precious name we pray. Amen.
Amen.
Amen. Everybody received the agenda in their packets this past week. Any question on that or any discussion before we approve it?
Move to approve as written.
Second, by Dr. Frida Singletary.
All right, we got a second. All in favor?
Aye.
All right, the agenda for today is approved. Are there any questions on the February meeting minutes? That was our last meeting. I did not. I make a motion to approve the meeting minutes for February.
Second.
All in favor?
Aye.
Aye.
Oh.
All right, the prior meeting minutes are approved. Now we're going to move into public forum. Do we have any members from the public? I see none. So we're going to keep on going here. Moving here to the departmental updates, and our department focus this month is the maternal and child health with Ms. Rivers and Ms. Hawkins.
Hi, good evening.
Good
Can
evening.
you guys hear me well?
Yeah.
Okay, awesome. So I'm Carlotta Rivers, and I'm the maternal health coordinator with Scotland County Health Department. I'm just going to share briefly with you about our maternal health clinic. It has been in operation for many, many years, but officially what I see is 1945 in the manner in which organized community health has been extended in this county. So we provide low to moderate risk prenatal care to pregnant women and their families because we provide education to them as well. They begin with the pregnancy counseling appointment at our agency, and if they choose to come to us or they meet the criteria to come to us, then they're given an initial visit. And then the next visit is their initial physical, which is done by our advanced practice provider, who is Ashley Locklear, physician assistant certified at our agency, and then they follow along with their regular schedule. We basically provide the prenatal care, and we also work with Scotland Memorial Hospital, who we contract with to provide coverage for our patients. Our patients deliver at that facility in labor and delivery, and then depending on whether they have a vaginal delivery or if they have a C-section, they come back to us for a postpartum visit. If they have a C-section, then those incision site check appointments are scheduled in the private sector. But other than that, they come back through family planning for their postpartum visit. And the reason for that is if they receive birth control through 403B, then they have to be admitted into the family planning. So that's why we do those visits in the family planning clinic. We have a lot of support services at the agency. We have SIMHART, which is care management for high-risk pregnancies. So there's a social worker, and all the patients are referred to that program, and depending on the score from their pregnancy risk assessment, whether they are actually assigned a care manager or not. And we have WIC, of course, in the building, and DSS at the opposite end. So one good thing about the location for our prenatal clinic is that it's like a one-stop shop. So those wraparound services are available in the same area, and that works well, particularly for patients who have issues with transportation. Are there any questions?
Yeah, so what's the, you said they were low to medium risk.
Yes.
What is the most common risk factor that you see?
Well, there's many. So when I say that, that means that low to moderate risk patients can come see us for prenatal care. Sometimes that may mean that they have a pregnancy within 18 months. So pregnancy spacing is recommended that you wait at least 18 months before another pregnancy, and sometimes it's less than that. So that could be one. Something else could be if they have a history of a preterm delivery. For that, more than likely, we would consult the patient out, depending on the other issues or other problems that they may have had during the pregnancy. But things such as if they are a gestational diabetic but is diet controlled, they can come to us if the provider co-manages them with our supervising OB physician, who is Zeta Patel. And she works at the Women's Healthcare Center of Carolina. She's a Scotland Memorial Hospital OBGYN. But if the patient thinks that they absolutely have to go out for would be like a twin pregnancy, twins, multiple gestation, if they're diabetic and on insulin, if they're on hypertension and on medication, so the higher risk things they have to go out for.
So those risk factors, when she say moderate to like low to moderate or moderate to medium, they're not like community risk factors. They are determined by like the OB. They're more like medical risk factors. So if they're a high risk pregnancy, so sometimes if you, they call it AMA, so advanced maternal age. Sometimes when they do those tests, you may be older than 35 and you may have some other screens that may factor you out into a higher risk that can't be managed like just in their clinic. So they're really just saying like they're pretty much equipped to handle mild to moderate risk pregnancies. But whenever you go into those things where you may do your fetal ultrasound and notice things and it's a higher like medical OB risk, those are the things that they have to refer out to like a private OB that's going to be able to, because that care is going to either be more frequent or have higher cost associated with it because of the monitoring and screening that may be required. So like that risk is more of a medical risk of how they use to determine who can be seen in hours. Like you have to be a lower medical risk.
So are these also people who are uninsured potentially? Is that part of the criteria, or?
No, we see patients who have Medicaid and uninsured patients.
Medicaid and uninsured.
Or underinsured. The Child Health Focus will be rescheduled to a later meeting. Joy had a scheduling conflict, so she was unable to be here tonight. But she will discuss child health with you in the future.
Thank you.
Okay.
Thank you.
All right, Tim.
Good evening.
Good evening.
Good evening.
This is the financial update as of March 31st, 2025. Once again, accreditation requires me to say that you all look at the 10 essential public health services before we make any financial decisions in the health department. And I was able to put these in your packet this time because of the small delay. So, do you need a copy?
I do, if you have one.
You can have my copy. I can read it.
Thank you.
So, expenses as of March 31st, 2000, I said I could read that. As of March 31st, March 31st, 2025, I'm gonna have to step over here because I can't see. We should be at 75% expended. We are currently at 67% expended, so we're currently still under budget. Any questions about the expenditures? I did add an additional slide at the end that hopefully can clear up a few things that we had last meeting. Come questions. Any questions on the expenses?
On the adolescent pregnancy, that's way underspent. Is most of the spending gonna be in the last quarter?
Yes, sir. We have most of the spending for the Reducing Infant Mortality Grant and the Adolescent Wellness Grant and the ICO Form CH will all take place, actually have taken place, most of it's taking place now. It's just that it's been purchased in April and has not been purchased in March, so the numbers not showed up yet. Yes, sir.
Okay.
I have a book of requisitions where things have been ordered, so yes, sir. Any other questions?
Not on this slide.
All right, so the next slide will be the revenues. We are at 60%. We should be at 75%. There's some areas you will see, like I've talked about immunizations before, that are, and this does not mean, what this means, these numbers mean is what I budgeted as what projected revenues we were going to get. This is what we've received. So this is a budget, this is the budget revenues that I had at the beginning of the budget year. And you can see some are under budget, some actually we've received more than what I had budgeted for. For example, the SIMHARP, that is a Medicaid-based program. That means that the social workers program, they have seen more people needing services than what I had budgeted for. So
And what line is that?
that SIMHARP should be 5051.
And can you remind us how you create your budget? Are you using averages off prior years or?
I base it off of prior years and any, I do print out a report that shows with clinical numbers, how many people we actually saw in the clinic, how much money was actually received per year, and I do that for 2 to 3 years. And then I kind of average that out with the factor that this year, we have one provider and we have a part-time provider. So I did not increase revenues this year due to the fact that not having 2 full-time providers. I left it pretty much the same
Yeah.
because I was not sure if the full-time provider would ever come back. It's just part-time at this time.
So seeing the numbers come in above or below budget, it just is really an indication of where you're tracking on for the average of prior years.
Yes, sir, that's correct.
Yeah.
Any questions? The next slide is the new slide. This is one that's broken down by program that shows you how much the county is putting into each program. I'm going to call it county allocation / profit / loss. So this slide will let you know per department how much the county, percentage the county is paying into that program. There are some that the county doesn't pay any right now into because, like TB, for example, we receive more in revenues and then we've actually used in expenses because we are down a TB nurse currently, CD nurse, so that has not, as under revenues are more than expenses. Also, you can see down at the bottom where it says animal control, 100% animal control is fully funded by the county. And you'll see some that say 0. Those are federal grants that are fully funded by those grants and not the county. Does this slide help you out a little bit more?
Yeah. Do you, I guess COVID grants is going away?
It's gone. As of May 31st, there are no more COVID grants. Yes, sir. So in the next budget year, you will not see that number.
Some of those COVID grants went away early.
Yes.
So let's take something like environmental health, just to make sure I understand this. Expenses year to date, 217,000. Revenues collected, basically those are the fees that we charge for services.
Correct. Yes, sir.
So basically, the services really only pay about 12% of the actual cost.
That is
Fee for
correct.
services.
That is correct. The only other revenue we get from environmental health is for temporary food establishments. Let me take that back. The food and lodging. So for example, the number of establishments Valentine and her staff goes inspect, but we just got that money this month.
Right.
That's $6,000. So that $6,000 will show up on the next revenue report.
So if I skip ahead a little bit and look at the new fee schedule, those additional revenues by increasing fees should ultimately reduce some of the county contribution
As long as we stay steady with our
head count.
head count, yes, and the fees, the wells
Expenses.
and the septic tanks and the things that we're doing now, yes, sir.
Okay.
Any questions?
Thank you for pulling this sheet together.
Does that help you out a little bit and kind of see where the numbers go to and everything? The environmental health was a good example of how that works. So there are some programs that the county puts a lot of money into, and some of the that's why it's important when we talk about fees that we set them to help offset the costs from the county, so that the county doesn't put so much into the budget, to the health department's budget.
So when a person receives services, do we, at the end of each month, bill the state or somebody or take money away from an allocation based on services delivered?
It depends on what services, for example, I'll use family planning, for example. If someone comes into our clinic and for family planning and they are uninsured, we do not charge them. Of course, if they slide in the percentage to 0%, they don't pay. We get federal grant that helps make up the difference for those people who cannot pay. So that's why you'll see federal grants, Title 10 grants, and then the Healthy Mothers, Healthy Children grant, which comes in for family planning, helps offset those costs of people who come in uninsured, slide to 0, or people who come in and say they want to be confidential. If they come in and
So-
say they want to be confidential, we can't bill.
So at the end of the month, if we've seen 20 people for family practice or family planning, and each visit is worth $150, I'm just making up numbers. Do we, at the end of the month, withdraw money from this grant pot, so to speak, or?
Not per se at the end of the month. What we do as an agency is the amount of money, the allocation that the federal gives us, we divide it by 12 and we take a monthly allocation.
Gotcha.
And we never will meet all that. I mean, we bring down more money than we certainly ever would be spending out, if that makes sense. But it's not just for that, it's for other things. There's incentives that we give family planning patients to come see in our clinic. We give them gift cards, we give them goodie bags with socks and other kinds of stuff in it as well. But it's a monthly allocation. I divide the allocation by 12, and every month I pull down that amount. So
And then what happens to the amount that you don't use?
I have never,
So each month you spend the full allocation?
yes, sir.
So if you only see 15 people that month, you still use the entire
Yes, sir.
allocation? Okay.
Now, there are some programs that do not work that way. Family
was about to
planning,
say, that
family
would be a
planning
pretty
does,
generous-
family planning
I
is,
mean,
is
throw
a
me
little
in
bit
that
different.
fire
Family planning
patch.
is a little bit different. Now, when it comes to child health, that's totally different. You have to prove different things. And so the allocation is basically there for us to use to make up for, like I said, the people who are confidential and things. So
Sure. Yeah.
they do not audit it and say, we want to see how many people, am I correct in that, Elisa? They've never asked us for that information.
So you don't get $1,000 and then have to show how much of that $1,000 you actually provided in service?
No, sir.
Okay.
Is that?
Don't
so
tell
that
anybody.
You have to do, but you have to, so like when you're billing Medicaid, right? You
Correct.
bill for the actual services that they get. So when
Correct.
we're talking about our fee schedule over here, that's the, in-depth one. So like for an office visit and a vaccine and those things, you have to show that you did those in the patient chart. And
Yes,
then
that's
Medicaid
absolutely.
pay you for those fees, and that's a revenue that we can bill, but it is contingent of, the revenue we make is contingent on what we see
Correct.
in the clinic.
Yeah.
When I make that statement, that is purely based on me pulling down the allocation for revenues. if someone comes in,
Cause the federal
And-
grant is different from
yeah,
what
if someone comes in and sees something and they pay, then yes, that revenue goes against that line item where you see private insurance or whatever. This is made for people who come in who have slide to 0% on our sliding fee scale, have no insurance, or want to be confidential, or uninsured, or people who, like, for example, if we bill Medicaid for a certain, we bill the insurance for a certain amount. Our fee schedule says we're going to charge you $25 for this service.
So you
and
have
the
to put
insurance,
this service is what the federal grant will pay.
yeah, insurance will pay $15. Then the other part is written off, but that money helps assist with
To offset
the
what's
offset.
not covered.
Offset. Yeah, that's
So
correct.
is that a monthly kind of thing, or, so if you go in and have an office visit, get an examination, immunization, does that package of services get billed at the end of that month,
Currently, our services are billed the next day.
the next day?
Yeah, so that's what he says, that like our billing, our revenues are a month off. Because you can bill them in, but they will not pay you, they don't pay you out
For a certain number of
immediately. And
days.
usually that payout is like a month behind. So that's why our revenues are typically like when he posts them, a month behind. But that was one of the things I can say when we started, like was one thing we asked him to fix, was because they were like weeks behind on billing.
Yeah,
And
so
but
that's
now
really
they're
my
doing the
question.
next day.
Yeah.
That means that now that so these numbers are more true numbers to what we're really bringing in and what we may be expending out. But with the federal grant, it basically covers if someone has these same fees that like Medicaid's gonna pay us back this amount. The federal grant is what covers this for our confidential, this same fee that we would still charge for the same offices. So the same $250 for the visit, the federal grant's covering $250 as opposed to us filing it on the Medicaid.
Correct.
Okay.
And then when you've got line items like you were asking about the adolescent and it's got 0, that, a lot of that is incentives or safe sleep classes and different things like that. We can't draw that money down until that service is provided, whether, I'll use like Teen Fest or something that Jana may have. Whatever she spends, like if she hired a DJ for them or gave the teens the incentive to come to the class, once it's done, we have to wait on the bill to be paid, and then we can draw it down from the state the next month, so it's a lag. Like anything she did in March, if it's not paid by the county to April, we have to wait until all that's done before we can pull the money down from the state.
So we can be assured that whatever service we're providing, we're billing whomever
Yes, sir.
pretty quickly.
Yes. Our medical biller, Demetria, she bills next day. She gets the billing sheets or encounter forms and goes into the EMR every morning, and she is billing the next morning what is done the previous day.
Okay.
So-
Yeah, we can control billing. We can't control when they pay.
Yeah.
But at least we get them billed, and, you
And
know,
it's
if
a
you're ever
video money
audited, you can say, hey, you know,
We do have another, I do have Dora, who's another employee who does the denials, and she researches anything that's not been paid, and she resubmits those things. So unfortunately, Blue Cross Blue Shield has always been an issue with us, and it's beginning to still be an issue with us. But most insurances will pay, but some are slower than others. So Medicaid's actually pretty fast now. Medicaid used to be they only paid once a week. But now they've got to where they are a little bit better at paying.
Any hunch on why Blue Cross takes longer? Is that just an internal process that they haven't figured out as well as others?
One of the issues of Blue Cross currently with us is an internal issue that we're working on.
Internal in our house or
Internal in
their
our house, yes. We are currently trying to rectify that situation.
Okay.
So I will let Amanda speak on that.
Reason like, county employees, we have Blue Cross Blue Shield. If they come in for a visit, for some reason Blue Cross is denying it, they're not credentialing us to do some of the services that we do. So like, if we wanted to have a employee wellness, it's not gonna pay us right now.
and why?
They're denying it.
They won't
There's some
credential us.
issue with our credentialing that we're working at trying to figure out. And Amanda is, I think, actually ask for some information on that because she's actually going to talk to
David Pope.
David Pope at the hospital.
That's
they-
interesting.
Was that a cold turkey drop? Or has that been a thing for a while of not?
Did it just happen,
Well-
like when they kind of did, like when did?
Well, Dr. Rosen's here, so I don't think he'll mind us sharing. They actually moved offices, and so, he's an employee with the hospital too, so when they changed the offices, they changed addresses, and somehow it dropped us off, and he's our medical.
It dropped us off of his credential. He's not affiliated with the health department. That's what we're trying to fix at this point in time.
Oh, okay.
So,
So that has
when they
nothing
change
to do with
when they change locations, they
Doesn't have
changed
the-
credentials.
anything to do
So-
with our
The health
ability to
department
provide the
Service,
service.
it's that they, in the, something dropped, some
The
technical
coding,
thing
yeah.
dropped off and. did
We are
not
trying. We
allow-
are trying to get it rectified.
So we've been on, or they've been on the phone with Blue Cross, and I was talking with April, and she said, well, why don't you just call David? Maybe he can work on it. So I got some information from Tim today, and I'm planning on speaking with David tomorrow and see if there's something he can do.
So is the reimbursement amount from somebody like Blue Cross Blue Shield superior to other payers?
No, it's about the same.
It's about the same, so Medicaid.
But for
Medicare,
Blue Cross Blue Shield at this point in time, we do not have we are not in network with Blue Cross and Blue Shield unless it's immunizations. Blue Cross Blue Shield will not pay us for anything other than immunizations because we do not have a primary care facility. Therefore, we're not considered someone they can be in network with, only for immunizations.
But we are primary care for some people, aren't we?
We do not have a primary care clinic per se. Donna, can you?
No, we do not have a primary care clinic. Our HIV, we've tried to slip by with using our HIV clinic. Cause I mean, maternal health and HIV, that is primary care in a lot of ways.
So
For
they
that
don't consider the
particular
family.
condition, but if they didn't allow us to use it to claim being a primary care provider. I mean,
So
you have
what-
to actually to be a primary care provider, you gotta have a bigger network than what we do, first of all. You gotta have a physician who can be willing to be on call and do all those things that we don't have at the health department.
Yeah, if we can, I think this idea of an employee health clinic is desirable. I think we're looking at pretty extreme cost increases in medical coverage, and I think we're gonna have to think outside the box a bit. And, an employee health clinic utilizing our resources is, I think, sort of the front runner of a good solution to provide care quickly to employees, high-quality care, convenient, but we need to have the capacity to do it. So I think we need to take it on to figure out, what do we need to become a primary care clinic, and is that within reason to do?
So I think like you and Amanda probably could meet on it because the things that you have to need are gonna be very plain. But I do know, like, one of the things for us is that I think we're probably gonna have to talk about later is like, we have to find somebody that's going to wanna work it. Because one of the things, like they said, is you have to have a MD that's on staff that's gonna work 4 or 5 days a week. And so we have to make sure that we are going to make that a desirable position. So the pay is gonna have to be there. We're gonna have to really ask and do some tough insight as to kind of what do we need to do to make that happen. Because if you don't have a nurse, if we can't keep a nurse, then you're not gonna be able to sustain a provider. So we have to make sure that we are gonna, like, I would say, staffing wise, like, we have to look and see what's that staffing gonna look like and what are we able to do now, and know if we don't have the nurses that we need now, or the, even the, mid-levels now, what can the county do to assist that? because that's really gonna be like the biggest thing is to pay for a provider
Yeah.
and the benefits for a provider and ensuring that it is a consistent support staff. So the nurse, because you don't want to have, 6-month, year turnover in your nurses. Because as a provider, you train up those nurses to know what you need, how you need it. So if we get somebody, we have to make sure that, okay, are we going to be willing to pay them not just now, but to keep their pay desirable to come here?
Yeah.
and
Well, first
work.
things first, what is it, let's find out what's required. Because, we can talk about it, but until we know.
Yes, that's what I'm saying.
we
Those are the things
can't
we
really, we can't
know
really
those are
make
gonna be.
decisions about how many and what and who until we kind of understand what's required. So if we understand that, then we can, and if we realize, look, we can't take on that financial commitment to do that, then that's our answer. But I think there's more than one way to go about this, and let's see what the rules are.
So to be clear,
Have-
I saw you writing, but to be
Yeah.
clear, we're asking Amanda to look into what would be needed or required to have a primary care facility, staffing needs, things like that. What
Yeah.
are what's
Because
the
I'll tell you,
package?
I could see a scenario where it could be, not a all-day clinic, or it could be some variation of that, where it might be just in the mornings, where people have an opportunity to wake up, you don't feel well, you come in and like a sick call, if you can, from a military thing, you come in and you see a provider, you get some help, referral, whatever you may need, and then you're able to return to work or go get a script or do whatever you need to do. I just think we could scale it once we understand what's required. And I don't know what our employee uptake would be, but I think the convenience of the health department makes it easy for somebody to come here first thing in the morning and potentially be seen, and be able to go to work or, go on to whatever they need to do.
I will say, having been through this process in the past 13 years, probably 7 times, we've been to Blue Cross Blue Shield to discuss primary care. Their main things, there are 2 things are always, you don't have a primary care clinic, you don't have someone to call on call, and you do not have a doctor on staff.
Yeah.
If you had a medical doctor on staff or a primary care clinic, then they would consider you in their network.
Yeah.
That has always been the two
I'd like to
issues.
understand how urgent cares work,
I will say.
because they don't seem to meet all of those criteria by any means.
But they have a doctor on staff.
I will say,
Or they-
That is the main thing. Like, really, I'm gonna be honest. Like,
Or
that's
they
why
contract that with somebody to provide that oversight.
there either gonna be a doctor on staff, or there has to be a doctor that is willing to take on those medical liabilities for those patients, right?
Sure.
And so,
Yeah. Let's just see what's involved, because I think, I'm serious about this cost of insurance.
so I've reached out to some of the other counties, because I know you say, reach out and see what your neighbors are doing. Number one, I came from Richmond, where we had an employee clinic. We did not have a doctor on staff, but we had our medical director, like Dr. Rosen, that would sign off on our nurse practitioners and our physician assistants.
But
And-
Amanda, wasn't that, did y'all do primary care or you did emergent care?
We did both. Okay, I'll use me for an example. I'm diabetic. So I was able to go to the nurse practitioner there every 3 months, get my A1C, all that, and she'd write my prescriptions for my diabetic medications at the time. I got high blood pressure. She did my high blood pressure. But, some counties don't do that. They just do, like you said, emergent. And I reached out to some of the other counties on that, and there's one county, in order to save the county on insurance, what they did was the commissioners took a pot of money and they put it there to say, hey, this is for the employees that might have a sinus infection or just little acute things, and they could come to the health department, and that was billed to that pot of money and wasn't billed to insurance. Therefore, that reduces your insurance claims for the county, which brings down your raise. So by them putting that pot, the commissioners will still allocate money, but it helped the insurance premiums. Does that make
I'll
sense?
tell you,
That's one.
there's
what one
self-insurance models out there. I'm just saying, we are reaching a point where we are really gonna have to think hard about how to preserve the quality of benefits at a cost that we can afford. And I think the old models are not necessarily gonna help us in the future. And we've just gotta be willing to sort of understand the environment and see what's possible. And I think the health department is a logical place to.
So
an
can you
asset.
work with Amanda to like kind of help with those? Because she's gonna need some insight from like a county commissioner, someone who knows about those other budgets. Because we just have our small view. You have more of
Right.
the extra that she needs about that full. So I think you and
Well,
her
I
working
think
would
this
be.
is where the whole idea of reaching out to other counties, Richmond County, for instance, is self-insured.
Yeah.
That, to me, is a whole new world of, I don't know the implications of that. But I'll tell you what, I'm not above asking and finding out, how's that working for you? Are your employees getting the services they need? And are you able to sustain that? So I'm just preparing you that we need to put on our thinking hats because it's coming.
And the employee
Yeah.
clinic would work very well when we could do it and get reimbursed for it. If we could take Blue Cross and Blue Shield, which at this point in time, we cannot take our own employees' insurance.
I don't know if Blue
So
Cross and Blue
that's-
Shield will be our future provider.
So that's the issue we're having now. When we had Cigna or we had
knows?
First Carolina Care, we were getting paid. We could get paid for stuff like that.
I just,
But at this point in time with Blue Cross and with our insurance currently, we at the health department will not get reimbursed.
yeah,
I do know when I was an employee in Richmond County, and, you know, I was seen through our employee clinic. If I came in, not only, you know, my chronic conditions, but if I came in and was sick, then I could go over and see the nurse practitioner on county time, and she'd write my prescription, and I'd go pick my prescription up at lunch, all on county time. So that was like a perk, a benefit for the employee, because you're not having to use your time for something to go in. And at the time that I was there, they had First Carolina Care. The health department would bill the insurance, but if there was anything left, you know, like the deductible, whatever, they never billed the employee. They just accepted what the insurance paid out. You know, if the claim was 150 and the insurance paid 100, then the employee didn't have to pay that other 50. So that was considered a benefit too.
Yeah. Thank you, Ed.
Thank you.
Thank you, Tim. All right, I got my agenda buried under here somewhere.
Oh, there you go.
Clinical events.
Yeah, we're looking for the clinical update from Ms. Page. All right. Ms. Oxidine, give us the environmental health update.
Good evening. Just a couple of things. Spring and summer's usually our busiest time for events in the county. We've had a couple events happen lately. Laurinburg After 5 kicked off April the 11th. That'll be every month, probably until about September or October. It's usually one time a month. We had the Suds and Swine event, April the 12th. We got good feedback off of that. I'm sure they were pretty busy out there with all the barbecue they had. We had the circus on yesterday that I permitted. They're usually here for one day, so we permit their food vendor. Future events that's happening in the county is the Sheriff's Department's cook-off is this weekend on Saturday, and the fun run. Sheriff's Department will be blocking off the whole Main Street. They will have a stage, and they'll be doing a cook-off. That the proceeds will go back to the Advocacy Center for Kids. And then the fun run is through the hospital. We will also have Laura Fest May 9th and 10th, just to kind of put the word out there if you know anybody that's looking to attend an event on the weekend. Those events will be coming up. Recently, I got a plan review application for Waffle House, and you'll probably get some calls about this because A lot of our folks like to go and hang out and drink coffee at the Waffle House. But they will be doing a remodel of the establishment. They will be closed doing that upgrade. When I called and spoke to the contractor, he said it usually takes about 30 days. They'll kind of get in there, they'll do a deep clean, and any issues that they run into, they'll go ahead and fix it while they're there. I've been here 5 years and they've not done an upgrade since I've been here. So it may take that long. With animal control, they're continuously working along with the Humane Society, with the take of cats and dogs. We received an email today from the director, Ms. Joe, letting us know that if anybody calls with an owner surrender, that they are to call the shelter to schedule because they don't have enough of a room to put all the cats and dogs coming in. So they're putting them on a schedule and they're taking information from them in order to bring them in.
So does that mean if I want to surrender my pet, that they'll just tell me we don't have an availability for 2 weeks, and then I can bring it in 2 weeks?
From what I gather, there's a process that they're following with that, with an owner surrender. I guess because they're coming up and they're saying, and that was one of the things she said in the email, you have a bunch of people that's coming up saying, well, we've got a stray, when it's actually their dog or their cat,
Gotcha.
and they're just running out of room.
So we were talking about this today in the meeting I had with animal control. Do you know the status of the two? I guess there was a boarding facility on 501 South, and then there was something in Wagram where there was going to be a shelter for dogs and cats.
I can only speak on the shelter that the Coolies have built or that they submitted for, because we did a septic application for them and also a well application. From what I gather with them is, they own the wedding venue in Wagram, and they had a lot of strays. Well, they've been boarding those strays there. They have little houses and kennels and things set up out there for those strays. And the shelter is I don't think it's gonna be a licensed shelter. I think it's just gonna be a rehome for the strays that they have at the wedding venue to be placed there.
Oh, okay.
From what I've gathered,
So it won't be overflow, it won't be excess capacity that
I don't think
perhaps-
it's gonna be somewhere where we can take a licensed shelter that's regulated by the state to where we can take overflow from what we pick up there.
So does such a place exist in Scotland County?
Not that I'm aware of.
In discussing this in prior meetings, I think this was last year, maybe even earlier, I think we reached out to some other counties as well, or at least encouraged the Humane Society to do so, and I don't think space was available, at least at that time, and I don't think the problem has really changed much.
The other counties are having some of the same issues.
Yeah.
Yeah.
Have we received any calls of that nature asking us about space? Well,
We have
would-
not.
we don't
called
really,
us.
yeah, wouldn't really called us, but
Yeah. Another thing I wanted to speak on is annually our animal control officers collaborate with the local veterinarian offices here in Scotland County, and they do a rabies vaccination clinic that happens all the month of April, so 1st through 30th. Those veterinarian clinics are the Academy Animal Hospital. They're taking appointment only. X-Way Hospital, and then the Scotland Veterinarian Hospital. The cost of that vaccine is $13. If you know anybody that wants to have their cat or dog vaccinated for rabies. And that is all I have. Any questions?
Has there been any consideration of expanding the shelter?
We wouldn't know.
Yeah.
They haven't mentioned it to us.
The Humane Society
I
is-
do know that they just did some renovations on some of their older kennels. I think the state required them to do that because some of the kennels were closed for a few weeks, but they finished the renovations on
Yeah.
those. But
That's correct.
as far as expanding, they haven't mentioned that to us.
Because I understand too that it's pretty difficult to meet all the state requirements for becoming a shelter. So it's kind of a barrier for people to kind of get in that business, so to speak.
I'm sure. Yeah.
Okay,
Thank you so much.
thank you.
Amanda?
Okay. So, the first thing I have on my report is the staffing report. One thing that's not on here is, I no longer have an admin assistant. As of today, Christine Russell is no longer with us. So that position will be posted very soon. The advanced practice provider, we have contracted with Emergis, and we currently do have a contract worker, that works 20 hours a week with us, and she actually applied for the in-house position. The problem I have run into there, and Emergis didn't have that in our contract, that there was a time frame that the person had to be with us before she could apply. But I found it out because not only did the advanced practice provider apply, so did the nutritionist that we have contracted with them. And I thought once their 13 weeks with us was up, that we could hire them. But unfortunately, on the employee's contract that we don't see that they signed, they have to work with the same facility for 6 months before Emergis will release them to become
They got you.
a permanent employee.
Can we pay that out? Is there a,
Well, it's not on our side, it's on the employee's side.
right, but
But I spoke with,
sometimes when you hire somebody from a temp agency, you pay like a $10,000 fee. They then will allow you to hire that employee.
so I spoke with the county manager today. Me and her had a long discussion on how we could kind of work around this without having to spend out a lot of money. The nutritionist, she will be free come August, so it's just a few more months. She's interested in staying with us until that time. I haven't had time to talk with the advanced practice provider. She will be free in September. So April and I kind of come together to say, let's just pause with advertising because the work's getting done. We've got people in place, and we've already interviewed them, and they're gonna be great candidates because they'll already have the training when they're finished, and just bring them in once their contract ends with Emergis. The WIC director / nutrition position has been vacant since November. We've posted it numerous times, but unfortunately, we haven't had any qualified applicants for that position. Public Health Nurse 1, we have 2 positions open there. We've done some interviews. I don't know why people apply for a job if it's not within the salary range that they're looking for, because the salary range is posted and we discuss it in their interview. But then when we choose a candidate and we tell them what the pay is, they decline the offer. So it's been reposted again.
Do those candidates tend to counter out of the range? Is
Yeah,
that how
way
it
out of
plays
the,
out?
way out of the range. I had one recently that countered $20,000 out of the range.
Makes no sense.
So we have reposted, the 2 Public Health Nurse 1 positions. We have 2 Public Health Nurse 3. We've frozen one of those, and one of them's posted. It's posted to, I think, May 9th.
Any applicants there? Is it a similar
No.
story? Or?
Similar story. No applicants really on the Public Health Nurse 3 because there's more qualifications that you have to have, which we could do a work against, but if you don't have a Public Health Nurse 1 candidates, it's hard to find a work against
Yeah.
for the 3. But the way we are feeling that is we have 2 PRN public health nurses that, one is, well, I think both of them are former employees that are working like a day a week. Donna's been doing the communicable disease for the Public Health Nurse 3 because she's training that. And the supervisors are actually having to fill in for the Public Health Nurse 1s. Carlotta, Elisa's here because we're short-staffed. I mean, we don't have enough nurses to run the clinics without using the supervisor.
Thank y'all for your efforts.
Yes.
They go above and beyond. I think Donna's probably glad that COVID in the past is over with, because it all started during then, and I don't think she knew that she was going to still be doing communicable disease and being the DON, but
5 years later.
so, but they do a wonderful job. I've got wonderful staff that they pick up the ball and go with it when they have to. Social work 2 vacancy, we have interviewed and we've made an offer. She's actually doing her pre-employment stuff now. So hopefully we'll have that person in by May 1st. Public health nurse PRN pool is still posted. We've had a couple of interviews and we offered somebody that, but they declined. But we do have 2, as I said, that were former employees that are working for hospitals and doctor's office. They're coming in on their days off and helping us some too. So that's where we are with the staffing. We did fill the health educator position. That is infant mortality, and she'll also be doing some work with the adolescent pregnancy program. She'll be working with Jana. She actually started April 1st, so we're glad to have Daniqua with us. Updates.
With your staffing right now, where does use of the van, the bus, where does that stand? And I don't want to step on if you're getting ready to go into that, so.
Yeah, I'm getting
Alright,
ready to
good.
go in it. The mobile unit actually right now needs repair. The leveling system, is having some issues, and Donna reached out to the manufacturer about the repairs, but they haven't let us know for sure if it's covered under a warranty or whatever. We're still working on that. The Women's Health Satellite Clinic that we have at St. Andrews, now that we have the contract provider, she's working on getting trained, and we're trying to get a public health nurse hired that could go out with her. Once that happens, we will resume at St. Andrews. But in the meantime, we're also offering late clinics once a month on the first Tuesday of each month that would fit in with that grant. We haven't had any takers so far, but late family planning clinic. And it would still come out of that St. Andrews grant.
When's the last time the mobile unit moved?
Moved off the property, or
Yes.
just moved from one spot to another? Cause it's
How
been
about-
cranked up and moved around. It
How
just
about
hasn't-
move to,
It's been,
Probably
To
the
help
back
people.
school events,
yeah, probably,
August, September.
August of September last year.
So that's been due to staffing challenges, and now there's the mechanical issue that's,
And we still
Hold
have
us up.
staffing challenges. I mean,
yeah,
to go out in the van means to shut clinics down in the building.
yeah.
Because when that mobile unit goes out, you're gonna have to have a nurse, you gotta have a provider, you've got to have your billing person. And right now, we don't have the nursing staff to put it on the road.
so is that basically a nurse, a PA, and a billing person?
And lab, I'm sorry,
You
Erica.
actually have to have 2 nurses if you get immunizations, so you have to actually, or you have to have someone there in case something goes wrong with the immunization, a backup and a nurse, so. But if we go out on a clinic, like do blood pressures and an event or something, that's not that big a deal, but if it's an immunization clinic, it takes place.
So is the billing person there to just, what is their role?
Not necessarily a billing person as much as a registration.
Registration
A
person.
registration, okay.
They register them in our EMR system, get their insurance information and information to bill the business.
Okay.
accreditation, we're still, continuing working on that, making sure all of our policies are current and that, you know, everything, we have all the activities completed. Budget, in the budget for this year, I requested 2 animal control trucks, renovation of a front area to construct either an office or storage area, which is that up front area behind registration. There's a lot of open wasted space there. And as y'all know, I've brought to y'all several times, we're short office space and storage area. The HIV case manager position that we have now, that funding will run out April 30th. So I've asked the county to pick that position up. I put in a position request for that, so that we don't lose the HIV case manager. What that HIV case manager does is, very crucial to our HIV patients, making sure they've got their medications, making sure they have housing, food, whatever the social determinants are for that person. And I would really hate to lose her, but currently her position's being funded with COVID funds.
Does that run to the end of the fiscal year?
April 30th.
April 30th, okay.
So did we not have an HIV case manager until COVID? Or-
That was before my time, so let's ask Donna, that was before I came to.
So, prior to COVID, we contracted our HIV clinic with, federal funds, with, through, now we have state, we contract through Robeson County Health Department. We're like a subcontractor for HIV. So they get the Ryan White money, and then our patients come in, and and we see them in our area. When we first started, I wasn't here when the HIV clinic started, but it came about because Robinson Healthcare Corporation was not, they didn't have a provider in Laurinburg. And Ashley, our PA, actually worked there with HIV patients. So we signed up to be a subcontractor with RHCC to do HIV care. And then before COVID, they opened up the office across from the hospital, and they got a provider in there to do HIV care, and then they wanted to pull our contract. And that's what they did. So we were able to get funding through Dogwood, which is Robeson County Health Department, and it's actually state funds, not federal. So patients who are eligible for Ryan White can get their care through us, through their Ryan White, and they pay for it. I have since, back to answer your question, Robinson Healthcare Corporation came with their own care manager. So she would come to our health department weekly and see patients while they were coming through our clinics and do.
So is a case manager a social worker or?
Typically, yes. Now, I'm a certified case manager,
Okay.
and I do some of the HIV case management too.
Right.
That was something else I absorbed. And so I typically handle more of the medical side, like to make sure that they get their meds, that they don't have to pay thousands of dollars in HIV meds every month through either the drug companies or through Ryan White. And then the care manager, that's the social worker, she helps with HOPWA and travel and different, housing, different things like that to make sure that they have food and shelter. And I have asked if we lose that position, are we required to have that position to be able to be a subcontractor with them? I'm afraid, I don't want to lose the HIV clinic, but I think that's a potential for that to happen if we don't get that position
I think we
funded
need to come
part-time.
up with a plan of what we can potentially do. Is the population, I seem to remember from a slide somewhere, is it like 24 people or 70, some number of HIV cases in the county?
No, there's a lot more than that. We actually see 42 in our
Okay.
clinic.
42?
But there's a lot of people, a lot more living with HIV and AIDS
Yeah.
in Scotland County.
I guess we just need to really think about how can we go about doing this, because with the status of federal funding, I just don't anybody who can tell us what's gonna happen has a crystal ball, because none of us know right now about grant funding coming down from feds, then state, to us, so.
I do know that, in Trump's, and I want to take care of people. I don't deal with the politics much, but what I do know, because of when we were trying to get our PrEP program to help prevent HIV, and so I had to do a lot of research and stuff in front of boards and whatnot, but in Trump's first campaign, when he was president, he actually started the end of HIV. He gave big money to hotspots in the United States. So he is very pro-HIV. I don't see that, I've heard some rumors from the reps that the Ryan White funding will be taken away. That's not gonna happen, not through, I just don't believe that, because he is very pro HIV reduction and elimination, and so I don't think Ryan White's going
We have a
anywhere.
county grant writer now, so I think one of the things we need to do is probably get her really engaged. in this
Exactly, that would be
this-
wonderful.
Thing too, so why don't you reach out to her tomorrow and say?
I don't even know who it is. Who?
Well,
It's Joy Hines, but she don't officially.
Oh, it's Joy. Oh, okay.
Start that position until May 1st.
Oh, okay.
May 1st, but I would at least send her a note and say, hey, this is something we discussed, and it might take us a while to get some grant funding, and maybe we can bridge something. But we need a solution, so.
We do. Yep, and I've absorbed probably as much as I can, and I will say this, and I am on camera, I hadn't gotten a dime for anything extra I've been doing for the last 5 years. The county manager basically said it was my job since I'm DOE and I should fill in for any position that's vacant. We've had one vacant for 4 years, and I mean, you can't keep getting blood from a turnip. You just cannot. So we got to have some solutions. I don't want to lose our HIV clinic, and I worked really hard trying to get PrEP in, and got funding through the Walmart Foundation and the Elton John Foundation to try to cover people who didn't have insurance to cover their PrEP services. And,
Well, dust all that off and talk to Joy, because I'm telling you, we put this position in here to try to find whatever funding we could.
yeah, and it's out there. You just need somebody who knows how to find it and do something.
That's right.
Yeah,
So
that's the big thing.
she'll partner with you.
All right, thank you.
Any other questions on that part? That's my report, unless y'all have some questions.
Are we gonna talk through the fee schedule?
That's later on.
It's on the agenda.
It's on there.
All right, moving to new business. Ms. Rivers for the child fatality report.
Okay. So, let me start off by saying this is the 2025 Scotland County Annual Child Fatality Report, and I have to present this to the Board of Health and the Board of County Commissioners because general statutes require that I do so. It feels somewhat monotonous because we have to do this every year, but it's just a state requirement. And plus, I do a PowerPoint for you guys with the Board of Health because I want to encompass and share with you some information specific to Scotland County, so you'll have that information. So the activities that were done in calendar year 2024 is what I'm going to be reporting on because it somewhat runs like a year behind. So this is 2025, but these are the activities that were done in the previous year. So the Child Fatality Prevention Team, or I'll reference as CFPT, is a combined team, and we work as a blended team with the Community Child Protection Team, and that's staff with DSS workers out of Department of Social Services, the CPS workers. So we also have community members. So that consists of the health director or the designee, health department social workers. I'm the maternal health coordinator, but I'm also the chairperson. Joy is the child health coordinator, but she's also the co-chair. And then we have our community agencies, law enforcement, the school system. And we have a few positions that are vacant as well. Some of the positions, such as the parent of a child who died, she had been a part of the team for many years, very, very loyal and dedicated member, and still is, but just her job situation rendered her being unable to participate in the meetings. If not for that, she would still be on it. So we will begin recruiting for the vacant positions. Our healthcare provider was our nurse practitioner who left in December. And so we'll hopefully get those positions filled, and we'll have those roles staffed. Our duties, we meet a minimum of 4 times a year. We typically meet 5, but in 2024, we did not meet in January due to the effects of the cyber attack that the county underwent. So, but we met the other 4 times, and that is the minimum requirement. And we meet and we discuss and bring information to the table regarding deaths of children from ages 0 to 17. These case reviews are then submitted to the state coordinator, and Christine, who was Miss Amanda's administrative assistant, she was also the review coordinator. So now we're short that position, and that's a very important position. That position does a lot. They send the releases of information to the various healthcare facilities that may have had interactions with these children and their families. She sends out letters, the invitations. When we have our meetings, she coordinates getting the food. She does the purchase orders for that. So that's a huge loss to our team. And we're going to need someone who's able to multitask to be able to fill that. During each local meeting, each member, again, they bring the information from their respective agencies. If they've had interactions with this family, for example, the family may have had interactions with domestic violence or law enforcement. So they'll bring the information that they have so we can try to get the best comprehensive picture on what this child was involved in, the environment that they lived in, and the immediate circumstances on what contributed to their death. If we come up with recommendations, then we formulate that on our confidential report that we send in after the case is reviewed. So what we're looking for is if there are any identified system problems or gaps in services, or any deficiencies in services that they receive, and we come up with recommendations to try to alleviate that in the hopes of preventing any future child deaths. So an example of that, just to make it more clear, so if there were an intersection and we noticed that there were 4 to 5 ongoing accidents and it resulted in a child death or deaths period, then a recommendation could be, let's work on seeing if we could get a caution light or a traffic light at that intersection, okay? So in 2024, we reviewed 7 cases, and the deaths occurred in 2023. So the causes of death were a 5-year-old black male, and that was other ill-defined or unspecified causes of mortality. That was medical issues. A 23-week-old preterm black female due to perinatal conditions. There was a placental abruption. A 28-week-old preterm American Indian female, birth defects. 36-week-old black female, perinatal conditions again, placental abruption, cardiac arrest, hypovolemia, and hemorrhage. A 15-year-old black male, actually 2 15-year-old black males that died due to a car accident, and a 16-year-old black male due to homicide, specifically gunshot wound. And I believe this is probably the 3rd year in a row that we've had gunshot wounds that were due to homicides in this county. referencing our activities and accomplishments, of course, our biggest thing is reviewing these cases. We shed a lot of light on the circumstances. And what we find is, even though typically we don't have a lot of recommendations of things that we can actually do about it, because they're more so related to social determinants of health, or the social drivers, the economy, their housing. But it stems a little bit more because it also affects the specific household, what's important. Contributing factors like substance use, alcohol use, illicit, drug use. Those things are often related to the cases that we review. So I won't go through each one of these, but basically, in addition to what I've said, the things that we do every year. We give you reports, we send in reports to the state. And this year, because we haven't had an audit in 2023, and before that, I think it had been 8 years since we had our state consultant come in and sit in with our meeting to do her assessment. But she will be back this year, and we are planning for her to be in the May meeting. And she comes in, she observes our processes to make sure that we are in line with what we're supposed to be doing. But this year, she will be also updating the team on the massive changes that are going on with child fatality. They made us aware of this around 2023. The goal is to make it more efficient in how child fatality cases are being reviewed in the entire system. They found that there was a lot of redundancy with child fatality prevention team and the community child protection team in the cases that they review, because the cases that they review are supposed to not be, the cases that child fatality review are not supposed to be due to abuse or neglect. But sometimes there's some crossover with that. And even if the death is not directly attributed to that, it may be undetermined, but there may be some underlying factors that suggest that. And the cases that they review are due to reports of neglect or abuse. So they're trying to revamp the system so that it's more efficient. Those changes were officially supposed to take place in January of this year. However, you can't make those changes until some things are put in place, like there was no training. The case review that we do and send in after the cases are reviewed, we have 45 days to send those in. Those reports are 2 pages. Well, now they're supposed to be 25 pages. But we don't know, we haven't received training on how to do those, what system they're going to be in. It's going to be on the National Fatality Review System. So that's going to be a huge undertaking. And I think they heard the local teams expressing that we haven't been trained on what to do yet. So we don't know how that's going to happen in January. So they listened. And so now they pushed it back to July. However, we still have not had the training for that yet. So that is up and coming. So hopefully when Carrie, and her name is Carrie Young, when Carrie comes next month in May, she will be able to update us and let us know what the plan is for us to be able to do what we need to do on the local end and send in. Also, Amanda requested gun locks. These became available through the North Carolina SAFE program, and that is an acronym for Secure All Firearms Effectively, to get gun locks out. So when she received those were passed out to a few of our community events that we had, and then the remaining locks were given to our health educator to continue to be distributed in the community. And for people who served on the team, I try to recognize them when they're no longer able to do so. So we did send a thank you card to Jenny Taylor. She works at Terrific Kids, the daycare directly across the street. She was unable to serve anymore, so we sent her a thank you card for serving on the team for about 5 to 6 years. And we always, during our meetings, we pass the word along about community events because we have all these different community agencies at the table. So as much information as we can share about community events, because Scotland County is a rural county, we want to make sure that people who are at that table, they are informed about any type of events that are going on that people and their families can benefit from. So for example, the Scotland Adolescent Wellness Council, the Teen Easter Egg Hunt that occurred last year, we spread the information about that, Scotland Memorial Hospital's pregnancy fair, anything involved with Parks and Recreation, and also the Scotland Community Collaborative quarterly meetings. If there's any information, we share that with our team. Okay, so, yes. So briefly, I just want to share some infant mortality rates with you. I did an average for Scotland County, and we just did a 5-year average from 2019 to 2023. I just wanted you to have a picture of some rates. So Scotland, it's kind of been up and down, as you can see, but our current average through 2023 is 9.7. Infant mortality are the deaths of any child that is less than 12 months. I did a comparison with North Carolina, so you can see how we compare against the whole state. And the next page, because we had a previous Board of Health member who asked, you know, in comparison to a county that was similar to ours. So of course we picked Richmond because I would say they're most similar to us in population and composition. And these are our rates compared to them. Their rates are a little bit more higher than us, but just so you can have something to compare to. So we will see how we do. They are gonna say that our name is called a unified local team, but we're still gonna call ourselves the Child Fatality Prevention Team. And as we know more, we'll definitely share in the future. There is one thing that I do want to share that we are doing this year. It'll be on the report next year, but I want to go ahead and share it because it is a benefit to this county. So we received an additional, I believe it was $1,700 this year to be used. Initially, they told us it was supposed to be used for the changes that we were undergoing, but since we're not sure what the changes are, I consulted with our state coordinator, and she said, just do it for something local that you know you need in your county. So in our SOCH report, we talk about how we want to work with children and daycare providers. And so I'll credit Donna with this because she came up with this idea. We proposed a couple of things, but our programs are really good with using the funding that we have available to do certain things like pack and plays and the money that we get for a Healthy Mother, Healthy Baby Block grant funds. We use that. So we don't want to already do something that we've done and have been doing for years. So Donna came up with the idea to pay for some funding, use some of our funding to pay for SIDS training and CPR training for local daycares. So she reached out to every daycare in Scotland County and successfully reached 10 and let them know that we have a small pot of money to pay for some staff to take that training. So out of the 10, 3 responded. So the ones who responded, because we have to have this money spent by a certain date, then that's who will get that money. It's going to be split evenly. So we wanted to make sure everyone had access to it. So that's the process we went through to make sure that they were aware and they had the opportunity to secure those funds. And does anyone have any questions?
Good stuff.
What were the number of deaths in '24 that you're gonna be reviewing this year? We were 7 in '23. Do you know the number for '24?
So far, we have reviewed one case, but we've reviewed two, but one was a re-review. And sometimes you'll do a re-review when there's not, when some information you don't have everything. So we were sent the medical examiner's report, and so we re-reviewed the case, but so far we've reviewed two.
I noticed on the Richmond, Scotland comparison, we didn't have a 2020.
That may have just been a oversight. 23 for Richmond,
No, for Scotland.
Scotland. Yeah, that was an oversight. I think it was 9 point something.
Yeah, so we, yeah.
It's 8.7.
8.7.
It was on the slide before.
Okay.
8.7.
I'll add that and have that added to your packets next time.
So is there anything that we can do as the Board of Health to help reduce infant mortality?
I would just say continue to support health agencies, our agency. You cannot, sometimes it's difficult to do more with less. We do a lot of great things in the county with the health department, but we also collaborate really well. You know, we work with Scotland Memorial Hospital, you know, things that are evidence-based like back to sleep and safe sleep. We promote those topics at our agency, and so do they. So we piggyback off each other when it comes to that. But I would say internally, we need staffing, and it's difficult to do. We all know in public health, you don't make a lot of money. We can't compare to the public sector in regards to pay. We know that. However, we could do better when it comes to comparing us to other public health agencies. It's difficult to do things like every one of my coworkers back here, we are multitasking and we're taking on extra duties, and it's hard to focus on things and do things really well when you're doing 10 things all at one time, because there's certain things that you have to get done and you have to prioritize certain things. Like clinic is always going to be a priority. Patient care is always going to be a priority. But when you have the time to sit down and think of things, like that's why Donna took this on, because when we got this extra funding, I'm working in clinic, the co-chair for child fatality is working in clinic. We're also in the middle of an audit for maternal health and women's health and family planning, so trying to get ready for that. So when you're doing 10 different things and everything's a priority, it's difficult to do. We need staffing. We need those 4 positions filled. We need the nutritionist, every position we need it filled, but it's difficult to do. And I know staffing's a challenge in the private sector, but we need positions filled. We need people who are gonna come and stay, because it takes a year to orient a public health nurse, but when you orient them and then a year later they're gone, you gotta start back over again.
So, you know, your example of offering this training to 10 daycares and 3 responded, right? Mm-hmm. So when we talked about prenatal care with new moms and stuff like that, is part of your program helping to prevent some of the things that happened? Or are some of these things that happened almost not preventable?
That a lot are not preventable. For example, like birth defects.
Yeah.
You know, there's nothing you can do about that outside of, you know, speaking on education and getting good early prenatal care. But if there's something genetic or hereditary that's going on, you can't fix that, but you can talk about the supportive things that are in place to help that mom with, you know, the next pregnancy. You know, you need genetic counseling, you need to get into prenatal care early. So we discuss a lot of social determinants of health and social drivers and wraparound services that can help patients get and patients and people in the community get the education and information that they need.
So new moms-to-be are participating in your programs at a much higher rate than the daycare example.
Well, I'm not sure that because daycares, this is just like a one-time, this is the first time we've done this. So when you say participating, I'm not exactly sure what you
But
mean.
I assume you have some programming, education, counseling, whatever, for new moms, right? To
Through
kinda help
the health department,
through-
yes, our
as part of
programs.
maternal health. And my question is, it sounds like people are really participating in that, or is it something that's available, but people aren't really
Well,
taking advantage of?
okay, so with any service, you know, we're available, and it's up to them if they choose to participate or not. Now, speaking with maternity, you know, we have criteria on some people may want to come to the health department, but they can't because we don't have a high-risk clinic. But over the years, our numbers in maternity for our prenatal clinic have dwindled down. For some reason, when COVID hit in 2020, our numbers have not been as they were. But all of our services are available. Sometimes you have people who participate, and sometimes you have those who don't. For example, with our SIMHART program, the care management for high-risk pregnancies, you have social workers who try to work with patients, and sometimes those patients, it's a voluntary program, even though it's being paid for, and sometimes they say, no, I don't want to participate.
Yeah,
So it's challenging in that respect.
yeah.
And we offer parenting classes, which also
Yeah.
teaches.
That's what I was gonna say.
And breastfeeding classes, so,
Well, that's part of the other challenge, right, is at the state and federal level, providing funding for these programs to do all these good things, and then people say, nah, I don't want that. You know, whether it's smoking cessation, weight management, you know, diabetes, whatever it is. And that's really the challenge, because we've talked about giveaways and incentives and all that sort of stuff, but it really relies on people saying, this is important to me. and
exactly.
Figuring out how to get people to that decision, so.
Right, exactly.
If they come, the reason they come most of the time, a lot of the time, is because they feel like you're gonna give them something, like either, it used to be a car seat or a pack and play.
Yeah.
That's basically what it was, because for the most part, if you're sitting there or standing there providing the education, they're either on their phone or chit-chatting with their neighbor, or it's like it's not as important as you feel like it should be. Hopefully, they leave with some really good information and considerate and that kind of thing. They leave with the information that they would need, but you just never know.
Yeah,
With the car seat, you know, even with the car seat, that's part of infant mortality prevention, you know. I mean, it goes from, like I said, from breastfeeding to birth control to parenting to, I mean, to taking care of themselves as for prenatal care to after birth care to, I mean, it's a long class.
it sounds like we have the whole buffet. We just can't get people to kind of show up and enjoy what's there, what's being provided, and that has to be a monumental frustration as well.
It is. And that is a big challenge in public health because we have a lot of education. We have programs that people can benefit from, but they have to take the initiative to participate.
Yeah.
Yeah, I was gonna say, cause that is overall in healthcare, like in our health department is here, like we used to say, like I grew up here, so I came here and did lots of things at the health department. Like I came here to get vaccines at the health department. When I grew up, I would come here for their they would have something like in the springtime, they would have something like different events, and I would come to those things, and it was an active thing within the community that they had going on, right? And it kind of goes down, it went down over time, and COVID, I will say, kind of tanked a lot of things that maybe they were doing. I didn't come until after COVID to the Board of Health. And so, overall in healthcare, I think that is something that like we all have to, kind of are struggling against, is that we offer tons of things. Even like our county, we offer tons of things, but we can't, the issue is getting the people to see the need to take hold of what's being offered, and 75% of it is free, whether it's offered through the, the hospital. And so, and we know, like you were talking about, like incentives and things, and we know that you can offer it, I mean, you can offer the world and they still aren't
Well,
coming.
and this
so-
goes to the resourcing issue as well, because when you look at it from a resource perspective, you say to yourself, you're spending X amount of dollars to help a very small number of people. And after you do that year after year after year, a common sense light goes off and says, wait a minute, I'm spending a lot of resource and I'm getting very little effect. Is there a better way to reallocate these resources? So
But I will
I
say
think
that,
that's a real challenge, and I think anybody who's got any business acumen gets it. And we have to rethink how we're going to go about this. And it's a huge challenge for everybody everywhere, because it's not just Scotland County.
yeah.
This is an epidemic.
But,
in a
and I
sense.
will say with that, like when we're talking about like, the budget and the resources and what you're allocating, even here, like, so as a Board of Health, like there are only so many funds, like the money we're talking about, a lot of these funds are predetermined allocations, right? So they're coming from state places, right? They're coming from federal funds. And, we can, as a local board, I feel like for us, yes, we can, I feel like we can try to do what we need to do to make sure that we are spending our local citizens' taxes and money effectively and efficiently. And I do like how they, like when the things were broken down to show us like what is that county allocation? Because with that, you get to see where are the county funds really going to, where are they not going to? Where are the things that we are spending money in as the county versus, and what are we getting back from where those county funds are being spent? The truth is, this infant mortality money honestly isn't coming from the county, right? Because that's true, that's all federal. So the county's not paying into that one, right? And so I try to look at what are these programs where the county's funds are going to, that where can we change, or do we need to do some changes from? But that
think
comes
even
with going
state
through
level.
peace. Yeah, but we
Even
as a
state
Board of Health
level.
can't do
Right.
that part.
But somebody at the state level is saying, as a state, we're spending this amount of money to serve this population. Where does that continue to make sense year after year after year? And I know as a county, we'll do what we can do. I'm just pointing out that there are levels above us that are doing this same exercise. And
And
It's
hopefully whenever they
important.
bring it down, we'll have to do our part to to manage that fund. And
shows its value, right?
Right.
If people understood the hours that you put into preparing
Yeah.
to do an educational program, and the cost associated with that, and then frustration of, out of 50
10
people
people
you're
come.
hoping to come, and you have maybe 9 or 3
Yeah.
that show up, and then have to clean up and pick up after everything that you've done, and then you go back to your office and you sit there, and you're right, it's very frustrating and they don't understand, and here's the thing, you can't expect people to understand, there's costs involved, there's time involved, because that's not what they're thinking, they're just thinking, here's a program that I can participate in, and those that wanna come will come, those who are made to come because there might be a reason that they have to come to participate, come, and then those who don't wanna come don't, or won't show up, and that's it.
Yeah, it's a tough nut to,
Back and go, well, that's what happened.
it's a tough nut to crack, and I mean, it's not just you guys, it's so many programs that we build in to do these wonderful effects that if people will simply participate and onboard some of that into their life, it can make such a powerful difference, like the genetic counseling you talked about and
Right.
stuff like that. I mean, what you're giving them is information about things that will dramatically affect them.
And I'll just share briefly, another challenge too is that the services that we offer, not just the health department, but other community organizations and state organizations. I'll take, for example, women of childbearing age. They may have 4 or 5 groups contacting them. They may have the SIM-HART worker, they may have the CC4C worker, they may have CDSA contacting them. And so it's like, okay, who are you? Who are you? I don't want all these people contacting me. So, the definition of insanity is doing the same thing over and over again, expecting a different result. So, maybe there'll be some changes in government from the top down to try to, make all these things work more efficiently.
Synchronizing that, because, I mean, you're right. I mean, you can only handle, a person who's pregnant and going through this whole process and probably working and many other responsibilities, how does this person really get these services in a way that they can handle it?
Yes.
Because, yeah, anyway.
If I might speak just a second on the federal funding, we do get a federal grant. You see the RNC grant, which is the money we get from the feds or from the state grant for reducing infant mortality. However, the allocation that does come down, we have to create a budget to send to them how we're going to spend the money. However, we can only spend it on things that they deem as, what's that word, Donna? Evidence-based. And if it's not evidence-based or shows that it's a factor in reducing infant mortality, then we can't use that money for that purpose. So they're giving us the money, but then they're telling us how to spend it. Does that make sense? So it's kind of got our hands tied. Here's some money, but you can only spend it on this, this, and this, and this.
I get that.
Yeah.
As strings. Thank you.
Thank you.
I do have an action item beside you on our agenda. Do you require any action from the board?
No, I believe that was done through the Board of County Commissioners at the December meeting. You did have to vote as to whether we were gonna move forward with a single county team or multi-county, and it was single. We've not had any other county reach out to us wanting to do a multi-county team, and the team doesn't want to do multi-county. And that's for, basically, sometimes it's challenging to get the members here at the meeting. So to try to partner with another county, and then we would have to sit there through not just our cases, and it's the cases for child fatality and the community child protection team, but their cases as well. But with the new unified local team, the mandatory meetings will be 2 meetings versus the 4, but it depends on how many cases you have to review, because you have to allot time for discussion.
Yeah. So no action required today. That's been
No.
handled. Thank you. And thank you for presenting.
Thank you.
Awesome job.
All righty. Looking at the annual approval of policies. Andy, do you want to go through those?
Yes. So annually, we have to review, the health department policies. The first one is the bad debt policy. Tim, these are your policies. Do you want to say anything on any of these?
Nothing has changed except for the very last policy as a recommendation from our last audit that we combine 2 policies into one. Actually, the bad debt policy is being combined into that last policy as well. The return check policy is pretty self-explanatory. The internal cash control policy, all that states is that we have internal controls in place. Who takes money, who collects money, who makes a deposit, who takes it to the bank. So we have a safe, who has access to the safe. So,
Any questions from the board? Like another moment maybe to read a couple things, or are we good to? Move
That
on.
came with the packets. I read it at home.
Yeah. All right. So we will move ahead here in the agenda, looking at the fiscal year 2026 fee schedule.
Try to be really quick. You received this, I gave you a revised copy, on your desk, at your seat. The only changes I made were highlighted in yellow. There was a, transposed number in that first column, the immunization column, and then lower down, we did change the rabies, vaccination cost because the cost just went up recently. So we changed that fee.
So these are direct pass-on, no markup.
The only thing that changed would be the ones in blue, which would be the private immunizations. We get a email quarterly from the CDC that says this is the cost of this vaccine, this is the cost of this vaccine. Our fee policy says that we take the cost of the vaccine, times it by 5%, round to the next dollar, and that's how we make money off of giving private vaccines.
So every adjustment on here is based on that.
Yes, sir.
And I noticed you even had a few that went down.
Yes, sir.
That's unusual.
Very unusual. Any questions on that fee schedule? I do need approval on the fee schedule.
I make a motion that we approve the fee schedule as presented with noted, correction and changes.
Second.
Ms. Little seconds. All in favor?
Aye.
The motion passes to approve the fiscal year 26 fee schedule.
The separate fee schedule is the environmental health fee schedule, which we talked about before previously. So what I did this time was I went back and took us out of the average, okay? Because our cost was low. So I redid the average, taking us out, and we proposed the average as long as the average was not 50% more than the current fee. Does that make sense? Because I know we had an issue, one of the board members asked about it doubling. So what I did was the average, as long as it was not 50% more than the current fee. That makes sense? Because we didn't want to pass on too much cost to the citizens. So,
Yeah, thank you.
So what's the question mark for the swimming pool?
so currently,
Don't have,
certainly we have a swimming pool seasonal permit.
Yeah.
That is people who seasonally have a permit, like your hotels and your motels that have, and that runs from, Valentine, have to tell me.
It usually runs from the time that they're permitted, so April 8th to October 31st.
So it's not for the whole year. However, we do have one facility that has a annual permit, which is St. Andrews, because they have a indoor pool. At this point in time, we're charging them the same amount as the seasonal permit. So I did not make the suggestion of what the cost should be. I was going to ask the board how they felt about the fee being increased for the annual permit versus the seasonal permit. And I'll take your recommendation. That's why it's a question mark. Because
so that we. just
Environment
make
Health
it
goes
the
one,
same-
they go one time to the seasonal, to do the seasonal, but for St. Andrews, it's twice. They go twice,
So you
two
make
times a
you
year.
make double the visits.
We have to do initial permitting and inspection, and then we go back in 6 months and do another inspection to make sure that everything's still within compliance.
Seems like 200.
200.
Seems reasonable.
What's that?
So make it-
200? Okay.
Based on 3
The
other
180.
counties.
and-
I'll tell you though, my question's on the
$20
tattooing
extra.
one. I'd like to understand a lot. I don't have
Yeah,
any,
for the
but,
extra visit out, yeah.
you know,
I don't have any problem with that.
we are higher than, well, more Hoke and Robinson are substantially less than us. Is there a reason for tattooing be 300 versus?
I do not have the answer to that question. That $300 fee has been there since I came 13 years ago, so I'm not sure.
I'm sorry, is this your area?
This is Valentina's area.
Why do you think that is? I mean, you probably weren't here when this was put in place 13 years ago, or were you?
I don't know, and I've kind of talked with, Ms. Erica in the past about whether or not they did like a class as far as like, hepatitis class in the past, to where they involved that into the training, cause when we go in and do an initial inspection, we offer some training like on bloodborne pathogen type thing. But I don't know, I don't, there was nothing ever set in place of why that fee was that high. We just kinda always charged it.
So for a tattoo parlor or a tattoo operator of some sort to get licensed to operate in Scotland County, they have to pay this fee, right?
Yeah, they'll pay the fee, and then they have to be permitted based upon the rules of North Carolina, that they have everything in place.
So is this a permitting fee or is this on top of a
That's a
permitting?
permitting fee,
Permitting fee?
yeah.
Does it also include inspection of their facility?
Yes, we issue a permit and we issue their first inspection.
And
And
then
that's
you're,
good for a year.
and you're saying too that you offer some sort of training as well?
We try to, but we don't have an extensive, like, deep training.
Okay, I didn't know if the state had some sort of online training or something that,
I can reach out and see if there's anything any other counties may have.
Do you know how many establishments we have in Scotland County, off the top of your head?
Food,
No,
Tattoo.
for tattoos.
we currently have 2 tattoo well, let me take that back. We have 1, 2, 3, 4. We have 4. And then some of the tattoo partners possibly have 2 artists in those.
the other thing is there's a lot of people doing homemade tattoos. And this may be part of the issue potentially for some people is, I don't wanna be licensed or permitted, I don't wanna pay these fees.
That's a good point.
And, I mean, I don't have any data to back up if they've hurt anybody or not.
Yeah,
But I think there's a reason these sanitation controls are in place
right.
to protect the public, right? So I would almost advocate reducing the fee to, well, but I'm not sure that it would achieve the effect.
Yeah. My question is for the like Richmond, it charges the 300. Do you know, like, do they offer a training to them? Like for them that offer this, like they offer 300, which is what we pay off, we charge now. Do you know if in Richmond they like, provide like a more extensive, like you said, like, you know, bloodborne pathogen, you know, Hep B training
But I
versus like Robeson County where
They don't.
that 50, they don't, Robeson or Richmond?
Richmond, I came from Richmond.
Really don't. Okay.
Can I ask a more pragmatic question? Is it more work to permit a swimming pool than to permit a tattoo artist?
yes.
Mm-hmm.
But with the tattoo artist, you're dealing with more of a, like the bloodborne pathogen type thing. Like they can only tattoo on certain types of skin. So you're kind of having to go through that process with them. They
What
can't
if-
tattoo on anybody with jaundice. They can't tattoo on anybody with rashes.
Right. So what about compared to like a nail technician or something? Is it kind of similar?
No,
No?
you're talking about injecting a needle into somebody's skin. So there's potential for there to be some kind of
Right.
crossover.
But I mean, even with nail stuff, there's a big fungus thing and, you know, there's a sanitation component. What do we charge for those kind of facilities?
They're not regulated by us. They fall underneath a different jurisdiction.
Gotcha. Okay. Well, it looks like the fee is going from, well, it's not changing. It's currently 300 and you're recommending it stay 300.
Yeah.
Okay, I'm not hired by the tattoo lobby. I just kind of noticed that we were a bit out of whack.
How many applicants have you had for the permit in the last year, 2, 5 years? Do you see them come and go a lot, or?
The two main tattoo parlors that we have here, like I said, they can have 2 artists in each one. And they change so much, cause, you know, they try to get new people in, old people leave. And so anytime a new person comes in, we have to permit them.
Gotcha.
So I would say in the last 5 years that I've been here, I've possibly had 4 or 5 artists, possibly even 6 that I've permitted, and then they left or otherwise had to permit again. Now we think about microblading, because
Yeah.
microblade with your eyes, your lips, anything like that falls up underneath us too. So we have 2 of those places here in Scotland.
Are you counting that in your 6?
Yes.
Okay.
Well, I guess we can leave it at 300. Just seems,
At the pleasure of the board.
Yeah, I'm gonna be honest, knowing the health and the other risks, I do feel like the health risks are higher with tattooing and microblading, because that bloodborne pathogen review that they do have to go over with them is important, and it's something that, you know, has other like health and legal ramifications. So you wanna make sure that they're aware, you know, they pay for that training and awareness. So I feel like 300 is
Leave it at is.
well, money won't buy you
fine.
better.
It won't, but it will also help with the training that they have to. It's not, the training she does may not be the in-depth one, but it is still a time, and you have to pay for those trainings. Like that is the bloodborne pathogen and OSHA trainings, they still are required at a cost that you have to pay up front.
Well, at least theirs is not changing, perhaps. Because it stays at 300, because all the others change substantially, so,
And they're not complaining.
yeah.
I just need approval.
I'd like to offer a motion that the swimming pool annual permit be, set at $200.
Second.
All in favor?
Aye.
And I'll make a motion that we accept the entirety of the environmental health fees for fiscal year 26 with the 200 set for the annual pool. So the entire sheet here, we accept that as. Is there a second?
I second it.
All in favor?
Aye.
And that motion passes as well.
All right, thank y'all so much.
All right.
And
Keep a copy of this. I think I'm gonna get some phone calls. When they double that,
yeah,
usually,
it's a change.
yep. When will the new rates go into effect?
This fee schedule will go to the Board of Commissioners, and it will be in the FY 26 budget ordinance.
Okay.
So it'll go in effect, July 1.
And we'll do some marketing and let people run in with their permits at the old price.
All right. Ed, I was gonna turn this next point over to you. I know me and you spoke on the phone just to talk about the consolidation that the Board of Commissioners is considering, just to give that framework of the dates of when things will be discussed and.
Yeah, so at our next Board of Commissioners meeting, the first meeting here in May, we're gonna have a public forum to see if anybody wants to offer any comment at all about the potential consolidated healthcare system or the review of our structure for DSS and the Board of Health. And then I think the members of the county commissioners are gonna discuss and come to some decision about the direction that we'll be taking in the future. So I think the focus of the board is entirely on effectiveness of the consolidated health organization. It's not a cost-cutting exercise. It's not envisioned to be something that's gonna generate, huge savings or anything like that. That's not the motivation. It's really a motivation about trying to make sure that we have the most effective structure to deliver services to people in our county. And we're gonna look at structure as a part of that process.
Do you know the date of that meeting for the public
It's
hearing?
the first Monday in May.
Okay.
May the
Yeah.
fourth,
May 4th, 5th?
May fifth.
Okay.
Is that May fifth?
May fifth.
Any other questions on that topic before we move on?
Yeah.
What would that look like when you say consolidation of the health department and DSS? What would that kind of?
So the state has approved several different, I think there's 3 different models the
Yeah.
state says that counties can operate in. And each one of them has kind of their advantages and disadvantages, let's say. And a lot of it's contextual, you know, what kind of county are you? Are you Mecklenburg versus Avery County? That kind of thing, right? So we can have sort of a current status. We can have a consolidated health director who is over both the health department and the Board of Health.
You mean DSS?
You mean DSS?
Yeah, I'm sorry, DSS. And basically, we're going to decide which model works, that we think will work the best going forward in the future. So we have those models to choose from, and that's what we'll be considering.
And depending on the model that's chosen, it can reconfigure our board and the voting power of our board. It could be a consolidated board with DSS's board. It could possibly alter Amanda's chain of command and her report, whether it comes to us as a board or whether it goes to April and then to the county commissioners. It's just there's some nuances to it.
Nuances in each structure.
Yeah.
Okay.
I guess I know, I guess my question is for when they go in like May, like this is for them because I'm like, it's like whenever if you do switch like to either one of those structures, right, you kind of have to, like there has to be it's a plan, a layout, a rollout, logistics
part.
of all that of each one. Like, so I guess for me, my question is like, even though they make that decision on whatever day, right, it still means that you have, well, before they make that decision, would they already have the plan of how it's gonna roll out?
Like a
Or would they
timeline.
make
No,
the
so-
decision and then devise a plan to roll out, or make a vote to say, let's go and develop a plan to roll out, cause
I
we need to
think-
have a plan first,
I
because it's
think-
like
Well,
it's,
enough counties have done it. There's kind of a plan already because with each structure, so let's say you use one structure, you have an advisory board.
yeah,
So there's steps, so you make the decision and then there's steps you follow depending on which
Yeah.
model you use.
Mhm.
But it's not gonna be everybody wakes up the next morning and the whole world is different.
Yeah.
It's gonna be a phased plan, no matter which way it goes. Okay, we made this decision, this is what we need to do next. And we'll sort of have a do list to go along with that. So it's,
Why did this come about? I'm sorry, I didn't mean to interrupt, but I mean, are things just not working? I mean, how did this kind of come about? Because I know we've talked about consolidation over the past years, and it just didn't seem to come to fruition for some reason or other, and, why now, maybe?
well, I'm not sure there's a clear case. I mean, it's not like there's an incident that caused it or anything like that. I think it's people are seeking an answer to how do we provide the best possible service to people in our county? And what's the structure to do that? And we kind of know where we are. What we don't know is what can be. And I think there's a sense of finding out what we can be. How much better can we be in performing this work? And each model has some advantages that can help you with that. So,
And I think it was on the report that the county commissioners received, and it was an overall arching county report on maybe optimization and efficiencies that could be reviewed, and it was something on there that, and I know this is,
Oh,
you've
yeah.
reviewed many of
Was it
those in the
in
past,
the-
the county board of commissioners have reviewed many of those in past months and maybe even years, but
I think too, you know,
I can't remember the name of it.
it's
Yeah, I
not,
think
it's
it
not
was
gonna
somewhere.
be an easy decision to figure out the best way ahead, but I do think that it's an important question to ask. And I don't know the outcome at this point, and I think all of us are waiting for the public comment, and we all have developed our impressions over time. And, you know, some people have been on the board a very long time and have impressions that date back a while. And I think we'll try to come to the best decision we can.
So is the problem with the chain of command, is that what they're looking at for consolidation?
I'm sorry, say that again?
Is the problem, I'm like Kathy, why now? What is the situation that has preempted this move? Is there a problem with chain of command from top down?
Like I said, I don't think it's one thing, you know, I think it's a sense that people have that there is opportunity to do this better. And is structure a part of that? Can it be part of that? And I think every organization is asking itself, you know, all the time, you know, can we do this better? What are the things getting in our way of doing this better? It's gonna be an interesting discussion, and I can't point to one thing and I'd say, this is why.
And I know we have to have community forums, but I have a feeling that community's not gonna show to give any input. It'll probably be more employees
Right.
giving input.
Yeah, and it'll be interesting to see, you know, because, you know, it will be a public forum and we'll hear people out. And
Will that affect funding that comes down the pike, you know, like for different departments, like say within the health department?
and as a matter of fact, a lot of counties across the state have gone to consolidation. This is not, we're not trying something that nobody's tried
Not a
before.
lot, we just actually legal, we went
There's
through our legal
statistics,
update, but
we
there are
have-
some, but there's more traditional than there are
Yeah.
consolidated.
Yeah, and
Wait.
so, and we've talked to other counties that have done it, and, you know, we're trying to make the best decision we can.
I think the concern, and this is probably, I'll probably show up at the community forum, because if this change consists of creating a new position to supervise our two directors of health and DSS, I think you'll be doing the county employees a disservice. Because you're gonna, I hope I've read consolidation a lot of what you got, I sent to Amanda, so I know about consolidation and I know what it means. But you've got two directors that would report to April is what I'm assuming is the way it would be. That's the model that you're leaning toward versus putting someone between April and Amanda at DSS director.
Well, I don't think it's fair to say leaning, because I don't know, I haven't heard that there's anybody
I mean, all we
leaning.
keep hearing is we don't have the money to pay for insurance for our employees, our budget's this and our budget's that. We might not get a cost of living raise, we don't get this, we don't get raises, our steps were cut back. And to create a new position that makes more than our two directors of services in this building over here, yeah, it's not gonna go over well with the employees. That you're
Yeah,
gonna create
I mean,
a
that's-
$120,000 position
That's one
to
perspective,
supervise
but,
those two directors.
yeah, that's one perspective, but, I mean, I've kind of tried to talk openly about, I think, some of the challenges we're facing, and I really do believe we're trying to get to the right place where progression increases occur, we have good health insurance, we're trying to do all these things in a very complex environment, and in pretty tough economic times for some as well. So we're this is not a cavalier decision that we're gonna make, but I think we have a duty to look at it. It's worked in other places. Is it the right thing for us? Or is the status quo good enough? We'll see.
All right.
I know which way you're leaning, so. That's okay, though. There's a lot you're not privy to, and people are working really hard to try to protect you.
And there's not a lot you're not privy to either, because we at the health department deliver excellent services, and we're not broken as far as our chain of command and how we provide our services.
Like I said, this is
And we
not to
feel
fix something that's broken.
Yeah.
I've kind of said that like
Then
3
why do it?
times, but,
If it's not broken.
well, ask the other counties across the state that have done it. I mean, you're not, you say you understand it, but you're not really kind of looking at it at a state level. They put this in place for a reason.
And again, there's more traditional than there are, I mean, we just seen the statistics at our legal conference.
Yeah.
It's not a statewide thing. It is very,
You know what?
it is the minority choice.
It's not a good thing or a bad thing. It is a thing.
Well, it should be good if you're planning on doing it. So.
Well, and that's a decision that we'll make. But to sit there and say it's a bad thing because only a few people.
I hadn't said it's a bad thing, I'm just saying it's a bad idea to create a position that multiple positions have been created in this administration when the rest of us haven't gotten a decent raise in 5 years. And there's brand new positions being created all through this county, and.
I appreciate the back and forth. I just want to,
That's one point of view.
I
will
appreciate,
say, though, Donna, I came from Richmond, which is consolidated, and we had concerns in the beginning as employees. I think it was the unknown that was kind of scary because we didn't know how things were gonna look. But then once it happened, we really didn't see much difference in the day-to-day. And there is several options that they can go to. I mean, they can have, like you said, create another position to where they would be over me and the DSS director. They can choose to take one of the directors to be over both areas, or they can put both directors directly up under the county manager. I mean, there's several different models that they can look at. But I will say, in Richmond, I honestly did not see a difference in the day-to-day operations. Now, a year after it started, I started to see where through attrition and as people were leaving, they started consolidating jobs. And I'll use this for an example. The lady that was doing finance, like what Tim does with us, the lady that was doing finance at DSS, she retired. So they kind of combined that finance department into one person, you know. They didn't replace the lady that retired, they just kind of pulled it all together. But the average employee, as an average employee I didn't see any difference in the day-to-day. It was mostly upper management that saw the difference. And I think our policies pretty much align with the state HR now as far as, you know, the career status that some people worry about and different things like that. But I think I'm correct in saying that our policies already kind of align with that. So I feel like we won't see much of a change in the day-to-day. It's just higher up. That's just my personal opinion. I didn't see a difference in Richmond.
well, I appreciate the correspondence, the conversation. I feel like we just got to have a little bit of, and encourage anyone and everyone to attend the May 5th meeting with the Board of Commissioners. And I believe everyone will be granted a moment to speak or share.
3-minute kind
Yeah.
of thing, like you do any public forum.
Yeah. So, just wanted to touch base on that, on our agenda. I know it's something that's been happening behind the scenes. We met with the School of Government.
School of Government.
Yeah, this
And
past
that
month.
was actually who provided our legal training last week, the same lady
Okay,
that
yeah.
we talked to on the Teams meet,
Good.
did the legal training, that me and Val and Donna went to.
And with something that impactful to the health department, I feel like it was due a moment in this meeting to at least acknowledge, so, and at least announce the date of when that hearing would be, so. Appreciate that. There is an animal control ordinance update that Amanda's gonna share.
Yeah, I just, made copies of this. Me and Commissioner O'Neill had a meeting this morning with animal control. And I have been going through this and looking. The actual ordinance hasn't been updated since 2017, so it's 8 years old and way before my time. And, I found a lot of the wording in here kind of conflicting. And so I think
So
it'll
what is
be-
in this pamphlet is the 2017 ordinance?
This is the 2017, so I put it in here so that maybe y'all could start to look at it now, and we can consider revising it. Maybe discuss more at our next meeting, or if y'all wanted to do a policy committee to work on it in between,
Yeah,
or.
I'll tell you the truth, Ian, I think we need a committee to work on this, because not only do we need to kind of straighten out some things but I think we also need to work with the city, because the consistency between their ordinance and ours, the handling.
Yep.
I think we need to expand the scope a little bit, and there's just some things, like right now, in there, it says our animal control inspects facilities, and the state does it. Stuff like that, it just
Yeah.
needs to be,
Streamlined.
yeah, it's changed, and we still have it in here.
Okay. And I know you two have discussed this. What do you envision as far as committee size? 2 from our board and maybe 2 from the city that could work together, or?
Well, I don't know, I think we ought to bring the city in on an ad hoc basis and look at their ordinance as we
Okay.
look at ours, and then have discussions with them about, hey, where are you guys leaning? Because I think Amanda pointed out this morning that bite reports are not coming from the city.
I've been here
As they're
3 years, and I have not received not one bite report from the city, even though I've contacted them and gave them the statute that, hey, if a bite occurs, you have to.
Report.
Yeah, I have to get a report.
Yeah.
And I found it odd that our guys have had 15 bites since January 1st of this year. So
And then you got 0 from.
0 for 3 years from the city.
Yeah.
And my guys are saying, hey, we know the city's had some, because when we take our animals to the Humane Society, they've got.
You're seeing
they've got-
others in quarantine. There's a reason that they're in
Exactly.
quarantine.
So there's some things we could tighten up, so I'd suggest, or I'd offer maybe that Amanda and I work on this with the animal control, and then bring the city in and see if we can get some coherency there. The other thing is, I think the county guys are working on city stuff, potentially.
Yeah.
And, how does that work?
Yeah.
And,
Great question.
yeah.
I'm,
so
I'm for it, for the two of you to
I
work
think we
together
can-
and,
I think we can work it out. I'm really interested in sort of decriminalizing some of this, because we're tying up so much time in court, and from what the animal controls officer said, we're not getting the effect. You spend months on this, and then a judge says $50 fine.
yeah.
You're like, we've gotta come up with a better way.
Okay. I'm for that. Do we need a motion from the board to assemble,
To
or?
establish a committee to review.
Yeah, well, I make a motion that Commissioner O'Neill and Amanda, you two work together to discuss the alterations that could be made to streamline this ordinance and to coordinate with the city as necessary.
And we'll bring it back to the,
And bring it back to the board with the proposed changes.
yep.
I make that motion.
I second it.
Just little seconds. All in favor?
Aye.
All right. So that passes. Any closing topics while we're in open session? We are going to move to closed session here in a moment.
I guess Ruth Miller is joining us.
Yes, we do have a new board member that was intended to own board today and to swear in. She was unavailable. She had a planned vacation, is what I understand, that conflicted with this meeting, but she will get sworn in at the following.
So where do we stand on board membership? Do we need any more members?
There's a open pharmacist position. There's an open veterinarian position. The optometrist is the now / public community member, which is the Ruth Miller position.
I think that, they actually put her in a
They
public
put her in
member.
And just the flat- the flat
open
public.
Community, cause we had an open community member, so we still have an open optometrist / community member
Okay.
position.
Yeah, okay.
So if
we
an
still-
optometrist moves to town, we can still
so we
seek
have
that
two
filling.
vacancies, basically.
The vet,
Three.
the pharmacist, and the optometrist / public member, so
So
three.
three. Yeah, we just need to continue to recruit and see if we can get people.
Yeah. Agreed.
Does Ethan as an advisory board be potential, or a potential advisory board, we
You
still
have to
need
have
those
you still have to
members?
have those same ones.
Yeah. All right, well, I'm gonna make a motion that we close open session, the open meeting,
Second motion? I second that motion.
and then, sound like we got 3 seconds.
Okay, sorry. I missed
No, that was
one.
good. All right, so all in